All this is Dr. Mobeen Sayyed from drbeen.com. Welcome to one more show. So today we'll continue our discussion in the series of androgens. Today we'll talk about anti-androgens. So these are the drugs and the therapies that would counter the effect of naturally produced androgens in us. So we're going to have a high-level overview. There are many, many drugs in this category. I'll go over where do these drugs act, what is the mechanism of action of these drugs, and what is the indication or why do we use them. I will not go into the drugs dosage or drugs route of administration. We'll discuss those separately. Now, the last part in this series will be to talk about androgen agonists. That is, for example, testosterone replacement therapy. So today's lecture is not the replacement therapy. Instead, this is the counter to the androgens. So let's start our discussion. So this is drbeen.com. Today, I have an honorary mention for Stephen Silver. Stephen Silver is my favorite artist. He has worked on many, many cartoon series. I actually got his book today, The Silver Way. This is a beautiful book. I think if you are a character designer, so I am a rudimentary character designer. I make eyes and face in round circles. But if you are a professional character designer, this book is really important to have. So with this, let's continue. These are the references. Gonadotropin releasing hormone. So we'll talk about that today. Resistance to anti-androgens. We'll talk about that. Clinical cancer research, another good one. This is a list of anti-androgens. Again, if you do not like this, there are other good sites as well, for example, Up to Date. However, these are the lists of various kind of androgens. I'm going to talk about their targets. And this is what are anti-androgens. Again, if you like, you can read it from other places. I have primarily prepared this talk from this book here that you can see. This is Goodman and Gilman, the Pharmacological Basis of Therapeutics, 13 edition. And this is the, if I go to the cover, this is the cover. Goodman Gilman's The Pharmacological Basis of Therapeutics, 13th edition. So with this, let's start our discussion. Apologies, it seems like I had closed my talk. So here we are. So the discussion is anti-androgens. That means the drugs that will cause androgen levels to be reduced or that would block the action of androgens. So here is what we will see. First of all, what is the classification of anti-androgens? What are the kind of anti-androgens? So if you remember, look at the previous, if you recall the previous lectures, you know that androgens are released. So from the hypothalamus, there is a message that goes to anterior pituitary, which would then release the follicle stimulating hormone and luteinizing hormone and adrenocorticotropic hormone. All of them in turn then cause testosterone or other androgens to be released. And then androgens or steroid hormones would enter a cell, bind with the receptor there and go to the nucleus and do their function. So the drugs are going to be acting at various parts of this series. So here, if you look at the classification, there are anti-androgens that reduce the testosterone secretion. So testosterone in males, in men, primarily is made by testis. So testosterone secretion hindrance can be done by various drugs. So here we'll talk about them. In this class of drugs, there are drugs that are synthetic gonadotropin releasing hormones. So this is, keep this in mind that we are talking about gonadotropic releasing hormones, and we are saying that when these drugs are given, the testosterone levels would actually decrease. It is a paradoxical phenomena that we are saying that releasing hormone would reduce the release. So we'll see how does that happen. In addition to that, we'll also see the steroidogenesis blockers, those drugs that would act in the tissue, for example, in testis, where steroids are made. So steroidogenesis means making of the steroids, and blockers are going to block them. Then there are another class of drugs that do not care about the androgen secretion and synthesis and release. They care to block the action of androgens. So in this group, we have androgen receptor blockers or antagonists, and we have androgen 5-alpha reductase blockers. These are those that would block the conversion of testosterone to dihydrotestosterone in prostate and other tissues. So these are various classes. What are the classes then? They prevent, some of the drugs would prevent the secretion of the testosterone, and some of the drugs would prevent the action of testosterone. So let's see them. Indications. Why are they used? We are talking anti-androgens. Why are they used? In men, scalp hair loss. So remember that these male pattern balding usually is because of the steroid hormones. So reducing the steroid hormones would, in theory, reduce the hair fall. Then problematic sexual drive or urges, or early puberty. So generally, over sexual drive in men can be then countered with anti-androgens. Benign prostate, these are the most important ones. Benign prostatic hyperplasia, or the prostate gland, it is increased in size, but it is benign, meaning it is not a cancerous increase, and all men would start developing or having their prostate size increase as they age. At some point, in some men, that increased size would press on urethra and bladder and cause obstruction of the urinary flow, and for which there may be drugs that are necessary. So benign prostatic hyperplasia or prostatic cancer. So prostatic cancers are also an indication. In women, acne, seborrhea. So acne are those pimple-like lesions that are also because of the oil that is in the hair follicle. Seborrhea are more flaky and bigger red lesions of the skin, once again because of the oil and the incorrect secretion of the oils and then infection of that area. So acne and seborrhea. Then hirsutism or excessive hair growth in women. Then scalp hair loss. Some women experience hair loss, which is sort of like male baldness. Not exactly that pattern, but there are patches of hair loss. Then high androgen levels, which in women, the androgen levels are supposed to be less other than estrogen and progesterones. And then, for example, in polycystic ovarian syndrome, where the ovaries and the estrogen levels are just high enough that the ovary is going in higher growth patterns as well for their ovas, and that is the polycystic ovarian syndrome. So these are the indication in which anti-androgens are given. Now in transgenders, especially transgender girls, so number one, feminizing hormones. So those transgender women who are looking to keep themselves feminized, they would take anti-androgens to counter the production of testosterone in them, and that would start creating feminization in their body. And then those girls, transgender girls, that means they were boys and now they are converting to girl, but they have not hit puberty. If anti-androgens are given to them, then their puberty is delayed, their androgen production is reduced, and so their masculinization is less. And so they will retain more and more of female or feminized features. So before we go to the mechanism of actions, what are the common side effects? Of course, anti-androgens, various drugs have their own specific side effects. But generally, from a high level point of view, if you say that, hey, if we are blocking androgens, then what are the general outcomes? Remember in our last discussions, we talked about it, that androgens have a couple of type of functions. One is the masculinizing function or male sex characters. Secondary and primary, even the development of internal genitalia and then external genitalia is governed by androgens. And then is the anabolic effect, and that is, stronger, bigger muscles and so on, coarse skin, hair patterns, and other such things. This is Luffy. So the side effects, of course, will be that when we block androgens, then these features will start reducing. So if you see, men have, of course, more men-like features. So when you give anti-androgens, men will show more side effects compared to women. So in men, hot flashes can occur, breast tenderness and gynecomastia can occur, because the lesser production of testosterone would then cause more activity of estrogen, and that would cause feminization. And when the hormones will act on male breast, that breast would start becoming bigger and tender. Feminization in general would start happening. Loss of libido would occur. Sexual dysfunction will occur. Infertility in some cases, and osteoporosis. So once again, testosterone and the absence of that can cause osteoporosis, which can then cause bone pains, and especially the spinal cord compressions can occur. Women usually tolerate anti-androgens better because they generally do not have masculinizing features. Because of that, if you block the androgens, they would not show a lot of side effects. However, still they can get hot flashes, they can get menstrual irregularities, and in premenopausal women, the osteoporosis can start early on. So these are the general side effects. Again, they are not for every anti-androgenic drug, but generally when you are blocking androgens, this can happen. So this is the summary of it. Androgens, now we know the androgens, anti-androgens, now we know the classes of them. We know when to administer them in men, women, and transgender women and girls. We know what are the possible side effects. Now let's go into the details. So if you just wanted a summary, here we are. Now I'm going to talk about the mechanisms. So for mechanisms, first we should once again review physiological pattern that we saw in the lecture 1. What that was here is hypothalamus. Let's start from the left side of this diagram. It is hypothalamus. We know that hypothalamus sends releasing hormones via the hypothalamo-hypophyseal portal system to the anterior pituitary. And anterior pituitary would in turn release various releasing hormones, for example, adrenocorticotropic hormone. I'm only talking about androgens and anti-androgens today, so only going to talk about 2 hormones. So adrenocorticotropic hormone will work on suprarenal glands and will cause secretions from there. And one secretion from there is going to be androgens. We talked about it in lecture 1. This makes up about 5% of all the androgens present in our body. Keep an eye on this one, because when we look at the mechanisms of the drugs, we'll have to figure out how do we shut off 100% of androgens, which includes 5% in here. So we'll have to see how to work on this one. This is Luffy and Kyrie. Okay, so the other releasing hormone, hypothalamus releases gonadotropic releasing hormone. This hormone works on the gonadotrope cells in the anterior pituitary, and those cells in turn release, again we're talking about men, follicle stimulating hormone and luteinizing hormone. And we know that luteinizing hormone in men will go to the testis and work on Leydig cells and cause them to create and synthesize and release testosterone. So here, this guy here with the T on its face is testosterone. Testosterone can directly go to various cells and function there, or it can go to peripheral tissues, the most important one being the prostate gland. In the prostate gland, there is 5-alpha reductase enzyme. That 5-alpha reductase enzyme will take the testosterone and convert that to dihydrotestosterone, which is also a very potent steroid hormone. And then this dihydrotestosterone will go into the cell as well. Now, inside the cell, there are androgens that can go to various tissues, get converted and go in the cell. There are androgens directly going into the cell. These are coming from the suprarenal gland, or there are testosterone coming from the testis to go into the cell, or testosterone going to prostate and getting converted into dihydrotestosterone and then going into the cells. All those pathways are possible. Inside the cell, we had this discussion last time that the testosterone or androgen will bind to androgen receptors, which are cytoplasmic receptors. These receptors are present in combination or bound with heat shock proteins. Once the testosterone binds here, the heat shock proteins will separate, they will decouple, and then two pairs of testosterone and their bound receptors will enter the nucleus. And for the healthcare students, you can remember two of them, as there are two testes, and so there are two molecules of testosterone that would bind to two receptors, and then that dimerized molecule set will go into the nucleus. Once it is inside the nucleus, as you can see here, and this dimer mean two of them, dimer will then bind to the genes with the androgenic receptor elements, or AREs. And once that binding occurs and the gene expression would occur, that would make messenger RNA. That messenger RNA would come out in the cytoplasm, go to the ribosome, proteins will be produced, and action will occur. This is the normal physiological mechanisms. We have done these in detail in lecture 1. Now we're going to put drugs on top of this mechanism to see what kind of drug blocks what part of this series of actions. So let's go there. So sites of actions. So starting from here, hypothalamus. So gonadotropic releasing hormone, GnRH. So pay attention to this one, because this is the only tricky one out of all of them. The function of gonadotropic releasing hormone, or GnRH, normal natural hormones function, is to cause pituitary to release follicle stimulating hormone and luteinizing hormone. Luteinizing hormone in turn will cause release of testosterone. So it would make sense. Hey, Luffy, what happened? You want to go somewhere? You want to go? Where? So give me 1 second. I think he wants to go out. Apologies. Okay, so it makes sense to think that gonadotropic releasing hormone will actually cause an increase in testosterone. But here we are saying that when synthetic gonadotropic releasing hormone is given, that would actually eventually reduce the production of testosterone. So this is the only one key concept to capture in this whole lecture. Everything else is straightforward. So here is how it works. The synthetic gonadotropic releasing hormones are about 100 times more potent compared to naturally produced GnRH from our hypothalamus, number one. Number two, the synthetic GnRH are made in a way that they have a high affinity for the gonadotropic releasing hormone receptors in our pituitary. Two. Now what happens then is that when a continuous stream of GnRH is given from outside, usually by injection, once a month, twice, once a month or every 2 months or 3 months. When it is given as an injection, what it does is it goes in and acts on the pituitary. And because it is potent, 100 times more potent, it kind of kicks those cells and says, make more testosterone, make more FSH and LH. So those receptors, when they get stimulated on these cells in the interior pituitary, the cells would respond and they'll say, okay, we'll make more testosterone, FSH and LH. And so there will be a surge of FSH and LH. But all our cells have this behavior that if you overstimulate some receptors, then our cells think, and they don't have brains, but inside their machinery would figure it out to say, well, I am getting too much stimulated by this receptor. I should reduce the number of receptors on my surface. This is very similar to, for example, let's say coffee. What happens in coffee? So let's say here is a cell and here is a receptor on it, and there are, let's say, 4 receptors. And normally, out of these 4, only one receptor at a time is stimulated, and that sends a signal inside. But if you send some medicine in, for example, coffee, or for example here, GnRH, and that goes and occupies majority of them, and not only occupies them, it actually really triggers them 100 times more potently, then what would happen is that this cell is going to start getting jittery and say, oh man, what the heck? Why am I so much stimulated? And the result is this cell would say, I am going to not produce so many receptors. I want to reduce this stimulation. This is like if somebody comes to your door and keeps pressing the doorbell again and again, you might just remove the button. So the cell would come out and say, you know what? I'm only going to keep 2 of the receptors outside. I'm going to downregulate the rest. I'm going to remove the rest. Because even with these 2, there is now enough stimulation that the normal actions of the cell can be done. This is the basis of addiction as well, or cravings as well, that if then you stop that substance that has caused the downregulation, then all of a sudden the cell has lower number of receptors. You've stopped giving the external substance, and this cell says, well, the internally produced substance is now less in number because it was coming from outside, so the receptors are empty, and the cell would now become all once again surprised to say, why are they not working? And then it would try to upregulate them, and it would try to be stimulated. That is what results in cravings and all that. So anyways, going back here, when the synthetic gonadotropic releasing hormone is given, anterior pituitary cells are going to become overstimulated. And then in the beginning, there is a surge of luteinizing hormone and a surge of testosterone. But slowly, within 2 to 3 weeks, the anterior pituitary cells would downregulate themselves so that they can respond less to the GnRH. When they would downregulate themselves, this whole cycle will become downregulated. Less LH will be released, less testosterone would be produced, even to a point that enough drop in level of testosterone occurs that we can say it is medical castration. It is equal to castration. Almost no testosterone is present. Or we don't say it is not present, we say the levels drop to the castration level. That is how potent this drug can be. And can you imagine? It is actually stimulating, but because of the overstimulation, the body responds by saying, not going to work for you anymore. I'm not going to produce testosterone. So that is one class of drugs. And they are very commonly used. They're especially used for the prostatic cancers and breast cancers. In addition, so this is in GnRH, correct? In addition, we can give GnRH antagonist as well. The one that we just saw is called GnRH agonist. We can give antagonist as well. That would actually do the reverse function and actually would try to block these cells and their receptors on the interior pituitary and try to reduce the LH. That is a normal behavior that we would expect. Sometimes you would give both of them together. But this is the only mechanism of action that was kind of paradoxical, so I thought it should be interesting to see. Anti-androtropins, in addition to this synthetic GnRH, estrogen is also another hormone that in men can reduce the production of testosterone. How does that happen? Look, when estrogen is administered from outside, estrogen would go and work in the body. At the same time, it will also go and connect with the cells on hypothalamus. Most of our hormones have a negative feedback system or a feedback system. What does that mean? When a hormone, for example, let's say GnRH, is produced, the hypothalamus that has sent that signal is expecting a response. So imagine if you are hypothalamus and you produce GnRH, what is the response that you want? You want more testosterone to be produced. So when the testosterone is produced and it is in the blood, you would now start measuring the level of testosterone. When you feel that the enough level has reached, then you would reduce the amount of GnRH production. This is a feedback mechanism. Estrogen is also a result of androgen hormone production. So when you give estrogen from outside, it goes and acts on hypothalamus, and hypothalamus says, oh, there is a lot of estrogen. That means I must have been asking to produce too many androgens. And it reduces the GnRH production, and that causes the reduction in testosterone production. So these are anti-gonadotropin hormones or drugs. These are synthetic GnRH. These could be antagonist to GnRH, and these could be estrogen. 3 primary types. Then let's continue. Second part. Well, let's go here, although I said 4, but let's call this number 2 for a second. Let's say the luteinizing hormone is released and it goes through the testis, and testis then produces testosterone. Now, for producing the testosterone, there are a couple of enzymes that are important in the steroid hormone production line. These enzymes are called CYP11 alpha and CYP17 alpha enzymes. They take cholesterol, and then in the cholesterol to steroid hormone function, they are part of that assembly line. They're workers in there. We can block them by drugs. So we will have antagonists to these enzymes. So when we block them, then what happens is GnRH is present. GnRH is present. So the healthcare professionals here and students, If you get the labs done, you will see that gonadotropic releasing hormone is present in normal or even higher levels. You would see that luteinizing hormone is present because the orders are coming in to make testosterone. What is not happening is that you're giving drugs that are blocking the production of testosterone. So what is not happening is production of testosterone. So you would see testosterone levels are less. So this is testosterone synthesis reducing drugs. So this is the second piece. Then third piece is that this testosterone will then go to prostate. And inside the prostate, the cells have another enzyme which we talked about last time as well, 5-alpha reductase. 5-alpha reductase will take testosterone and convert that into dihydrotestosterone. So if you see here, I made two water molecules with a dihydro, two waters with testosterone. Then this dihydrotestosterone goes into the cell and behaves like testosterone or steroid hormone. My apologies for my keyboard that makes noise. There are drugs that can block 5-alpha reductase. And these are the drugs that you would find in flccc.net. Those who would listen to this talk in the future, during the pandemic, there is a organization called flccc.net, and they offer in their protocol these two drugs to be used as well. So here, finasteride and dutasteride, these are two drugs that block 5-alpha reductase. So what is their function? Their function is to prevent conversion of testosterone to dihydrotestosterone. Dihydrotestosterone is a more potent hormone. So it is essentially sort of anti-androgenic behavior. Not sort of, very important anti-androgenic behavior. Now, that is three categories. What are the three categories? Either block the ordering hormones from ordering the production of testosterone, or block the production or synthesis of testosterone, or block the conversion of testosterone to a more potent form. And finally, the final common pathway, that is testosterone or dihydrotestosterone or androgens from here. They all eventually make androgens that would enter a cell, bind to the receptors, and make some action happen. So if you go inside the cell and block these receptors with which testosterone or dihydrotestosterone or other androgens come and bind, if you block these receptors, then it doesn't matter if we have testosterone. It does not matter if we have dihydrotestosterone. It doesn't matter if we have anything else. They would just not function. Why? Because the receptors are now occupied by a different drug. This is called androgen receptor antagonism or androgen receptor blockade. Now what would happen is, once you block this side, it doesn't matter now if we have the steroids or not. The type of drugs that work here are of two types. And actually, it's very logical. What is the kind of hormone that attaches to this receptor? Steroid hormone. So there can be fake steroid drugs, or we can say steroidal anti-androgenic receptor antagonists, or androgenic receptor antagonists which are steroidal in their structure. So their molecular formula looks like a steroid, and they would come in and attach here and they would block these receptors. Now when the actual testosterone would come in and say, hey, I want to bind to this receptor to do some function, the receptor would say, sorry dude, I'm already blocked, I'm already occupied by this other drug. I thought this was steroid, but it's a fake steroid, but now I'm blocked. So that is how you can block. The other group here is anti-steroidal. So these are also chemical molecules. They can bind with this receptor, but they do not look like steroids. So here, for example, anti-steroidal flutamide, and steroidal type spironolactone and cyproterone. Now here is an important thing to note. I want us to look at two drugs, spironolactone here and ketoconazole here. They both were not supposed to be anti-androgenic. Ketoconazole is a antimicrobial. It's an antibiotic drug. It's an antifungal drug. So it was for fungi. And it turned out that when they administered it to some people, they saw that there is an anti-androgenic effect of this drug. Just like we see nowadays, for example, ivermectin has a different function. Now, just like nowadays, you hear people, well, this is an anti-parasitic drug. How can this be an antiviral drug? Here you have an antifungal drug acting as an anti-androgenic drug. Or, even more funny, here is spironolactone, which is an anti-aldosterone drug. And it is actually a very good anti-androgenic drug. And not by blocking the synthesis of the androgens. It actually can block the receptors. It can bind to the receptors and occupy them. But it is a diuretic. It is an antihypertensive drug. And here we are seeing this drug that it can work as an anti-androgen. These are the off-label uses. This is not just the two drugs here. There are tons of drugs that have legitimate off-label uses because these molecules were found to do something else as well. And we studied that and we said, oh man, this molecule does this too. So I'm going to use it for that action as well. So spironolactone is a steroidal androgen receptor blocker. And flutamide is an anti-steroidal androgen receptor blocker. So now think about this for a second. This is it. This is the talk for today. But I want to now discuss some of the therapies and how they are given. Imagine there is a patient of prostate cancer. And we have decided that we are going to give them synthetic GnRH. That is usually the first line to administer for such patients. Now we have a problem. The problem is when you would administer synthetic GnRH for 2 to 3 weeks, at least 1 to 2 weeks, there will be a surge of steroids because the GnRH will cause anterior pituitary to produce a lot of luteinizing hormone. That would cause a lot of steroid production. That would cause steroid surge. Now we are already giving this drug because the steroid hormones are acting on the prostate and causing cancers. Plus, some cancer cells themselves also produce testosterone. So we're trying to block this whole cycle. But instead of blocking it, we are going to cause a flare-up. Why flare-up? Because the first 1 or 2 weeks, there would actually be an increase in testosterone. Then third, fourth week, the testosterone levels would reach a bottom line or castration level. So what do we do in that time frame? In this initial 2 weeks, if you're thinking like doctors, what should we do? What is the problem we have created? We have created a problem for the patient that there is more testosterone that would actually cause a flare-up of their cancer. It could even promote metastasis and even cause more issues. So what you do is the following. You add androgen receptor blockers. You add androgen receptor blockers. That means that even if there is more testosterone now, even when there is more dihydrotestosterone now, because you've given receptor blockers, that extra production or even normal production will not work. So on one end, you are working to downregulate the receptors in anterior pituitary to tell the pituitary not to produce more luteinizing hormone, and that would take about 4 weeks to become fully active. Meanwhile, you have a flare up to control, and that would be controlled with the receptor blockers. So this is called androgen deprivation therapy, or ADT. Androgen deprivation therapy combines the androgen synthetic releasing hormone plus androgen receptor blockers. They both together work in the beginning to create an absolute reduction in androgen's function. And then slowly you leave the GnRH administering and you remove the androgen receptor blockers. So that is one important area to consider. Second part to consider is that if you are giving the patient synthetic GnRH, what is the function of that synthetic GnRH? It is going to reduce the luteinizing hormone, which will then reduce the function of the testis to produce testosterone, right? But look at our friend over here. This friend over here, they are the same ones. But look at the mechanism here. Hypothalamus is still producing corticotropic releasing hormone, which is still causing anterior pituitary to make adrenocorticotropic hormone, which would cause the suprarenal gland to continue to produce androgens regardless of this side to become downregulated. So how do we now control this guy? This guy is going to continue to produce 5% or slowly even more because the other side is not producing much androgens. So for this control as well, what you do is you go back to here and you add androgen receptor blockers. Because at the end of the day, wherever the androgen is coming from, they need to enter the cell, they need to work on the receptors to cause action. So if you just block the receptors, then you have taken care of everything. In some cases, you as a healthcare professional might decide that I am only going to suppress this side and leave some of it there, just so that the person, the man, does not develop an absolute castration level. They have some level of androgen still available, some libido, some sexual function, some anabolic effects of the androgens. Or you could also decide, and this is normally done, that when you are going to do androgen deprivation therapy, ADT, where you give GnRH and destroy this pathway altogether, and you give the receptor blockers and destroy the function together, so you have caused a complete silence, then you actually give some steroid from outside, because a person cannot just live without 100% of steroids or at the castration level. So you might actually have to provide some replacement therapy as well. And you'll have to modulate that how much receptor blocking, how much GnRH, and how much replacement therapy may be needed. So as you can tell, that anti-androgenic function overall, and I have not actually gone through every single drug. If I can just very quickly show you, if you go in here and look at the list of drugs, these are all the drugs in various classes. And every one of them has a different dosage, different distribution, metabolism, and different side effects. So as a healthcare professional, you'll have to kind of know them all and work with them. But in the discussion today, I just wanted to make sure that we can understand the bigger picture for how these drugs are given. At the end of the day, for the summary of this whole lecture, just this diagram is sufficient. So with this, let's stop for today. Do me a favor. If you can, please like, subscribe, and share. I hope the audio was useful and correct. So please like, subscribe, and share. If you would like to support this work as well, there are links in the description. You can buy me a coffee, or you can use PayPal to support this work, or you can use Patreon. You can be a Patreon. I think I have to soon leave YouTube and go to Odyssey. It may be that YouTube would actually just shut it down. So their rules and regulations says that if there are 3 strikes in 90 days, then the channel would be permanently deleted. The strikes are occurring on the past videos. So the strike that occurred on Dr. Corey's video was, that video was uploaded in Feb. So YouTube didn't give me a strike since then, but they did it now, which tells me that, and they did a manual review. That means somebody asked them to do the manual review, somebody reported it. So it is possible that people would just continue to report. They are hustling with me at this time. So it is possible that within this 90 days, the channel is shut down. So I have all the content back on Odyssey, and I am now trying to figure out how to go live on Odyssey. There are some quirks in there that I need to master. I need to use OBS, etc. So give me permission for tomorrow to do a test with the Odyssey and the live. So tomorrow's test may be bumpy because I'll have to try that out. I would try, if the channel stays on, then I would try that such topics that do not irritate YouTube, we'll continue to do them here. My request to you will be that whenever you see a video from my channel, just like it and let it play for a few seconds. That gives me some revenue so we can keep earning from it. And then I'm going to continue to move with other topics on Odyssey. So thank you very much. Thank you for your support, your love, your care. And I'm going to see you in a few minutes in chit chat. Doug says OBS, open broadcast software. It is a streaming software which would then be connected to Odyssey, and then on my system, OBS will run, and that would do all of this, and then it would feed that into Odyssey, and then Odyssey would show it. Plus, Odyssey does not have, on YouTube, for example, half an hour earlier, there is this little, backstage pre-live where you can actually come online, you can get notification, you can do some chit chat. Odyssey doesn't have those kind of features yet. So we'll have to know exactly at 6 o'clock, here is the link and here is how to go live. So I need to do some research on that. So tomorrow I'm going to test it out. It may be a bumpy ride tomorrow, but please bear with me and we'll go from there. It does have live, I think, chat with it. It's just a notification kind of system is not yet very mature. Okay, cool. So once again, please like, subscribe, and share. And I would see you in a few minutes.